Hi folks, this is James and today we are using kalemics to describe the etiology of hyperkalemia. Not wasting much time, let's take a look. So by far we can say that renal failure is one of the major causes of hyperkalemia because the renal system helps in maintaining potassium levels by balancing the intake of potassiums with its excretion. The quantity of potassiums that enters the proximal tubules are avidly reabsorbed such that only a small fraction of the potassiums will find its way into the distal nephrons. Now, before we can understand how hyperkalemia occurs in the failed kidney, let us take a look at a normal scenario. That is a kidney that is normal. This is a distal convoluted tubule, and here we can see the aldosterone. Aldosterone binds to the mineralocorticoid receptor, and that activates a channel that is specialized in the reabsorption of sodium. That channel is called epithelial sodium channels. So the whole mechanism leads to reabsorption of sodiums. In other words, sodiums will then come into the intracellular compartment. All right. Now the reabsorption, if you notice, sodiums will go in, it takes the positive. So every time it goes in, it leaves a negative trace. All right. And that negative trace, we're going to call it an increase in electronegativity of the lumen. And this is what is very important because this is what helps the potassiums to be secreted because of the electrostatic gradient. Potassium is plus, and now there is a minus here. So the potassium can then run through this channel here that is also specialized for potassium secretion called the renal outer medullary potassium channels. This is used to secrete potassiums into this compartment. So when I say sodium delivery to the distal nephrons, it is very important because if you have less sodium getting into that compartment, then certainly that is going to lead to a less secretion of potassiums into this lumen. That is going to lead to hyperkalemia. So in renal failure, of course, there is a low GFR, and that low GFR will lead to less delivery of sodium to the distal nephron. So there is loss of that electronegativity that is created. This electronegativity, it is lost because there isn't even sodium delivery to the distal nephrons. And this is why the potassiums would not be secreted. Again, we also have another channel called MaxiK, which is also used in the secretion of potassium as well. So the sodium potassium ATPase is used also in balancing the potassium levels in the cell. So this is very important because aldosterone plays a key role because it is the hormone that activates the epithelial sodium channels, and in renal failure there is also a decline in GFR. All right, so potassium excretion is the reason why hyperkalemia occurs, and you can say that it is because there is less sodium delivery to the distal nephron, and also the activity of aldosterone may also be declined in certain instances as to activate the epithelial sodium channels. All right, so let's take a look at how acidosis leads to hyperkalemia. And here I want to emphasize on mineral acidosis. As in organic acidosis, the loss of potassiums from the internal part of the cell is minimal. So we would assume here to be our extracellular compartment, and here being the intracellular compartment. And there is acidosis, so there is a decline in pH. So a channel called sodium hydrogen exchanger fails. Once this gate is blocked or failed, we are not able to get sodiums into the cell. So the level of sodiums in the cell will decline. Now the impairment in the sodium hydrogen exchanger can also affect another cotransporter called sodium bicarbonate cotransporter. This channel also fails. And again, we are not able to get the sodiums into the cell. This further deteriorates the sodium levels inside the cell. So now the effect is there is less sodium in the cell. But recall that the sodium potassium ATPase that we have right here, maintains the balance of potassiums in the cell. So now that we have less sodiums, we are not able to exchange those sodiums with the potassiums. Hence, there is going to be more potassiums left in the extracellular compartment, which leads to hyperkalemia. Moreover, there is also exchange of these chlorides with bicarbonates. So the chlorides that comes into the cell is then used or as a co-transporter. These chlorides can even affect the efflux of potassiums so that more potassiums can get out of the cell, and this leads to hyperkalemia. So this is the reason why hyperkalemia occurs in acidosis. So recall that any disorder that leads to aldosterone reduction can actually cause hyperkalemia. So we have aldosterone right here. Aldosterone binds to the mineralocorticoid receptor. This activates the epithelial sodium channels. These channels are specialized in the reabsorption of sodiums. The reabsorption of sodiums creates something we call an increased electronegativity in the lumen. There is an electrostatic gradient because potassiums are positively charged, and the differences in charges is able to help potassium get secreted into the lumen. So that is done through, for example, the renal outer medullary potassium channels, or MAXI-K. In both cases, potassium is able to get into the lumen because of the increased electronegativity which is left by the sodiums. So that in part, of course, depends on the delivery of sodiums to the distal part of the nephrons. And potassium permeability on the luminal membrane increases to aldosterone stimulation. One typical example is a patient with Addison's disease. This patient can have hyperkalemia because in this disorder, there is a low aldosterone state. Tissue lysis. So this occurs when a tumor disintegrates and releases its potassium contents into the blood. This may occur as a result of the direct tumor growth or treatment from the cancer. Rhabdomyolysis, crush injury, and burns may also lead to release of potassiums into the blood. The excessive ingestion of potassiums by itself should not lead to hyperkalemia unless there is a concomitant chronic kidney disease or a congestive heart failure. Let us assume a patient with congestive heart failure. This patient is going to be advised to decrease their salt intake. So the patient will look elsewhere for replacement such as potassium salts. Now they think that they are getting rid of the sodiums because now they have potassiums. Now forgetting that the same patient with congestive heart failure has a poor cardiac output. So there is going to be a less perfusion of the kidneys, right? And this is going to lead to renal failure. And of course, this is a risk factor for hyperkalemia. This same patient is taking spironolactone, a drug which increases your potassium levels. So you can see that there is a couple of risk factors which predisposes the patient to hyperkalemia. Other than that, a healthy person that eats food rich in potassium should not have any hyperkalemia. Now let's take a look at some common agents that may cause hyperkalemia. But before that, you do recall that angiotensinogen from the liver is converted into angiotensin 1 with the help of renin. And angiotensin 1 is able to help us achieve angiotensin 2 with the help of angiotensin converting enzyme. This is a powerful vasoconstrictor, and angiotensin 2 is able to help with the secretion of aldosterone. So that if we have aldosterone, it can bind to these mineralocorticoid receptors, they can activate the epithelial sodium channels, and then it can increase sodium reabsorption. When sodium is avidly reabsorbed, it increases the electronegativity of the lumen. That electrostatic gradient helps with the secretion of potassiums into the lumen. So the take-home point is that if you reabsorb more sodiums, you would secrete more potassiums. If you reabsorb less sodiums, you would retain the potassiums in the cell. In other words, hyperkalemia. So AC inhibitors, ARBs, indirectly may block aldosterone and can lead to a reduction in sodium reabsorption, and that can lead to retainment or retaining of the potassiums in the cells. Spironolactone or eplerenone blocks mineralocorticoid receptor. These are the receptors here. When you block this mineralocorticoid receptor, you also decrease the activity of the epithelial sodium channels. So it brings us back to a decline or a reduction in the reabsorption of sodium, and that will lead to the potassiums retaining or being kept in the cells, or hyperkalemia. Amiloride, triamterene, lithium, and trimethoprim suppresses the epithelial sodium channels. This would lead to a low reabsorption of sodiums and certainly a low secretion of potassiums. Heparin can lead to impairment with the synthesis of aldosterone. And once we have aldosterone decreased, it leads to a decline in sodium reabsorption. Beta blockers can alter the uptake of potassiums by cells, and the non-steroidal anti-inflammatory drugs can also alter the synthesis of renin. Insulin deficit. Insulin and beta-2 adrenergic agonists both facilitates potassium cellular uptake by increasing sodium-potassium ATPase activity. So what I have here is insulin. And when it is bound to its receptor, it activates this sodium-potassium ATPase. Similarly, beta-2 agonists, when bound to the receptor, would also activate this sodium-potassium ATPase. So when this channel is active, more potassiums will go into the cell and more sodiums will come out of the cell. Now, a patient with diabetes mellitus who has a deficit of insulin would not have this receptor insulin interaction, and so this sodium potassium ATPase would not be active. Similarly, a patient taking a beta blocker would not have a sodium potassium ATPase channel active. This means that the potassiums will stay in the extracellular compartment and the sodiums will be in the opposite side. And this is where the potassiums will lead to hyperkalemia. So this is one of the reasons why we use both insulin as well as beta agonists such as salbutamol in the treatment of hyperkalemia. Inherited disorders such as hyperkalemic periodic paralysis, not to be confused with hypokalemic periodic paralysis, enzyme deficiencies such as aldosterone synthase or 21-hydroxylase, nephronophthisis, and glomerulopathy with fibronectin deposition may also cause hyperkalemia. Let's take a look at how a higher osmolality can lead to hyperkalemia. One of the major determinants of osmolality is your sodium levels, your glucose levels, and to some extent your blood urea nitrogen. So we have a patient with hyperglycemia or hypernatremia. In practice, this can be a patient with diabetes mellitus if it is hyperglycemia, and hypernatremia may also be seen in a patient with diabetes insipidus. So these parameters would make the extracellular compartment very concentrated because there is more glucose or there is more sodiums in this region. So once the concentration here increases, then you do recall that the water in the intracellular compartment will be dragged into the extracellular compartment. When the water is leaving, it will drag the potassiums along with it. And this is how the potassiums ends up in the extracellular compartment and leading to hyperkalemia. So we call that solvent drug, all right, where the potassiums will be dragged along with the water. And this is the mechanism by which the potassiums enters the extracellular compartment. Also remember that the intracellular compartment is made up of about 40% of the total body weight and the extracellular compartment 20% of the total body weight. Normally, osmolality is calculated by 2 multiplied by your sodium levels plus 10. This is if it is a normal patient. So if I take an average sodium, then it's going to be 2 multiplied by say 140, all right, plus 10, so that we get 290. Okay, so a patient with diabetes can have more than this. A patient with hypernatremia can have more than that. Spurious hyperkalemia, otherwise known as pseudo-hyperkalemia, is a false hyperkalemia. This may occur in vitro in hemolysis, fist clenching, or tourniquet usage when taking a sample. Severe leukocytosis or severe thrombocytosis may also lead to pseudo-hyperkalemia. So the leukocytes have a vulnerable membrane because it is not in a normal physiological condition. It lacks metabolic fuel, and this impairs the sodium potassium ATPase, causing the vulnerable leukocytes to release the potassiums into the specimen. Lack of heparin in the tubes for collecting potassium samples may also cause release of potassiums into the sample. Platelets may also degranulate on storage, hence it is important that we take the samples from the plasma pool. Thank you, and I hope this was useful. If you enjoyed it, then hit the like button and subscribe to the channel. Bye.